Now we're going to be doing Chapter 18, Personality Disorders. We're going to look at them more in depth, divide out our different clusters, as well as the clinical picture, the nursing actions for each one, following up with some age-related considerations, promotion of mental health, and then self-awareness. Cluster A, these are our odd and eccentric personality disorders. This is going to be our paranoid personality disorder, schizoid personality disorder, and schizotypal. Paranoid personality disorder. This client is going to have a marked distrust and suspicion of others. So the key characteristic here is that pervasive mistrust, suspicion. They might interpret others' actions as harmful. They may develop transient psychotic symptoms, especially during periods of stress. It's more common in males, and it often leads to lifelong difficulties in relationships and work. Behavioral patterns, you're going to see somebody who's really aloof, withdrawn, hypervigilant. This is somebody that's going to want to position themselves at or near exits. They're going to be physically distant. They might have some restricted emotions that are going to lack warmth, lack ability to empathize. Mood liability, they may shift from suspicion to hostility very quickly. They're going to frequently misinterpret other people's actions as evil or that they're out to do them harm. They're going to use a lot of projection where they're blaming others for their personal problems. And they're also going to have conflicts. They're highly conflict prone, usually with people in authoritative figures, which they might perceive a nurse to be an authoritative figure. So your nursing actions are going to be to build trust with this client. And the best way to show trust is through a very structured and straightforward approach. You're going to want to maintain a formal and business-like manner. You're going to want to avoid social chit-chat and jokes because your joke can be easily misinterpreted. You want to make sure you're punctual, that you keep your commitments, and you communicate very clearly. Involve the client in planning. It'll give them a sense of control. Encourage validation of ideas before acting on suspicions, and help them distinguish reality from their paranoid delusions. Key takeaways: clients with paranoid personality disorder struggle with trust and assume people are evil or that they're out to do them harm. They're guarded, they're distant, and those are their defense mechanisms. A structured, predictable approach minimizes anxiety and resistance, and we want to make sure we're helping clients with reality tests through their actions, which can help reduce unnecessary conflict. Schizotypal personality disorders, these guys are characterized by a detachment from social relationships and restricted emotional expression. It affects about 5% of the population. It's more commonly seen in males. These clients are going to avoid treatment unless life circumstances changes significantly. Behavioral patterns, they're going to be emotionally aloof, indifferent, detached. Minimal emotional expression. They're going to be cold and unfeeling. Little, no enjoyment for leisure activities. Passive, disinterested, even under stress. These guys have a very rich fantasy life, and those are usually more often gratifying than real relationships, is these fantasies that they build in their head. Highly intellectual, often engaged in solitary activities. These are people that are going to thrive in like an IT department and mathematics and things like that. But they really lack future goals, aspirations, or decision making. They're indifferent to praise or criticism or opinions of others. There's little to no social involvement. They rarely have friends. They rarely date. They don't often marry. They may live with a parent until adulthood. And then again, they're going to struggle with social cues of other people, and they're going to avoid social conversations. So you, the nurse, you want to focus on improving their ability to function within the community. We might need to do social service referrals for housing assistance. We can suggest care facilities that offer minimal social interactions, ensure that they're meeting with their primary care provider, establish a working relationship with case management for those essential services, encourage engagement with at least one trusted individual to prevent neglect of daily leads. So key takeaways with our schizoid personality disorder, these clients are withdrawn, they're detached, but they do not find this withdrawment and detachment as a distress. They prefer solitary activities, and they do struggle with social interactions. We want to do structured support systems to help them function independently. We want a predictable environment with minimal social demands. Schizotypal personality disorders. Core characteristics: social and interpersonal deficits, discomfort with close relationships, cognitive perceptual distortions, and behavioral eccentricities. May experience transient psychotic episodes under stress. This could possibly develop into schizophrenia. Physical appearance and behaviors. These guys are usually odd, unkempt, disheveled. They might have stained or ill-fitting clothing. They may be seen wandering aimlessly or focus obsessively on small details. Their speech is coherent but loose, digressive, or vague. They might be using odd or incorrect words. Their emotional affect is pretty restricted. It's usually flat. Sometimes they might be inappropriate or silly. They're going to have difficulty expressing or experiencing emotions like anger, happiness, and pleasure. They're going to have some cognitive distortions with ideas of reference that might, they believe events that have special meanings for them. They might have magical thinking, belief in having special powers like influencing events through thoughts. They could be paranoid. They could be suspicious, particularly about others' motivations. Their social anxiety and relationships. They're going to have intense anxiety around unfamiliar people, which kind of worsens over time. They have limited ability to form relationships, often only one significant relationship with a close family member. They usually live in their parents' home well into adulthood. For social and vocational challenges, they have difficulty responding to social cues. They struggle, and their struggling is even with superficial conversation. They may have useful skills but struggle to maintain employment without a lot of support. Mistrust of other, bizarre thinking, and appearance can also hinder their job retention. So as a nurse, self-care and social skills. We want to encourage a structured routine for hygiene and grooming to avoid that disheveled appearance. We want to practice role-playing interactions, especially with community members, such as their landlords or store clerks, to reduce the discomforts and to improve their communication. We want to support using written or phone communication. They find that a little bit more comfortable to avoid face-to-face because face-to-face causes a lot of anxiety. More social skill training that we can do is helping them to practice clear, logical conversations to reduce the bizarre speech, and designate one person to discuss unusual beliefs with, reducing inappropriate discussions with others. The next cluster we have is cluster B. Cluster B, as we noted from the first lecture, contains our antisocial and our borderline, and those are going to be our most commonly seen clients in the hospital settings. Your antisocial personality disorder, this is like the criminal, right? And again, we cannot give this diagnosis, no personality disorder diagnosis, until they're at least 18 years of age. So our core characteristics with our antisocial personality disorder, these are going to have just complete disregard for other people's rights. This is known as our psychopath or our sociopath. It occurs in about 3% of our general population and about 30% of clinical settings. More common in men, more common in prison populations. Antisocial behaviors peak in the 20s, they decrease after 45. When we get into the child or child disruptive behaviors, conduct disorder typically falls into antisocial personality disorder. So your nursing actions for these guys, you really want to have consistent limit settings. You want clear limits with identified consequences, and you must follow through. We want to specifically eliminate any unacceptable behavior. We want to ensure consistency and adherence to the rules and to the treatment plans. Confrontation can be used on these clients to point out the behavior problem and focus the client on themselves. We want to address behaviors in a direct manner, and we do not want to escalate conflict. Because remember, this client is going to have no concern for your well being, and they're highly manipulative. We want to help with problem solving skills, assist the client in solving problems and managing emotions, particularly the emotion of anger and frustration. Anger and frustration are going to be big problems for them to deal with. We want to help them with effective problem solving skills and reduce their impulsivity. For role performance, identify and address barriers to role fulfillment, focus on improving role performance, whether it's in work or social relationships. Substance use management, a lot of these guys will have that dual diagnosis where they also have some type of substance use disorder going on. It's best for them to decrease or eliminate the use of drugs and alcohol because of drugs and alcohol are known to exacerbate the antisocial personality disorder behaviors. The next one we have is borderline. So borderline personality, you're also going to see very often, these guys are at the highest risk for suicide. The core characteristics are pervasive pattern of unstable interpersonal relationships, self-image, and affect. These guys have marked impulsivity, they have a labile mood, and they have emotional instability. And one second they can be very happy and good, and the next second they can be very down, and it can happen multiple times in a day. It's common in about 2 to 3% of the general population. It's 5 times more frequent in those with a first-degree relative. Most common personality disorder in the clinical setting, as I said before, it's 3 times more common in women. These guys can also have transient psychotic symptoms under stress, high risk for suicide, high risk for self-mutilation. A lot of times they look at suicide as a way to express anger and numbness and to feel alive, and help with like their emotional pain release. They're also very manipulative, and a lot of times they might kill themselves or hurt themselves to punish and manipulate those around them. Some behavioral traits, we're going to see clingy behavior, followed by anger and rejection of help. Manipulative behaviors for immediate gratification. Often they're seen self-sabotaging their own treatments. A lot of mood instability and unpredictable behaviorals. And it often leads to frustration of caregivers and families. So your nursing actions for this guy. Safety, 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 right? If this client is going to be at risk for suicide or self-harm, safety is so important. So we want to discuss the self-injury thoughts, And we want to make sure that we're doing it in a non-judgmental manner. We want to prioritize physical safety and intervene appropriately for suicide ideation and self-harm behaviors. We want to assess the risk factors of self-harm. So are they angry? Are they having psychotic symptoms? Do they have access? And then we want to institute safety interventions during the crisis, especially when they're doing self-mutilation. For emotional coping and control, we want to help the client identify their emotions and express them safely. So, like through journaling, teach methods to moderate emotional responses and reduce impulsivity. So, helping them learn how that it's okay to delay gratification. Use cognitive restructuring techniques to help stop the decatastrophizing. This is the client that is going to have that catastrophizing thought process where, if I don't get released today, then my life's going to be over because nobody's going to be able to pick me up, and then I'm not going to be able to get home, and then I'm not going to be able to eat, and then I'm just going to die in the street, right? We want to help them get through that catastrophizing thought process. We want to encourage the use of positive self-talk and reframing of negative thoughts into positive ones. Therapeutic skills development, we want to teach social skills, effective communication skills to improve relationships, cognitive restructuring, and thought stopping. So this is really challenging for them, but very often these guys see things as all good or all bad. So we need to help them recognize that and challenge that thinking, and also encourage thought stopping, which is a technique to halt negative self-criticisms. And remember, the dialectical behavioral therapy is the therapy that's very specific for borderline personality disorder. The next one we have is our histrionic personality disorder. So the core characteristics of this one, these guys are going to have pervasive pattern of excessively emotionally and attention-seeking behaviors. They are commonly going to seek help for depression, lots of unexplained physical issues and relationship difficulties, but they're going to fail to recognize how their behavior is creating a lot of these issues. It's diagnosed more often in females than in males. It's found in about 2% of the population, 10 to 15% of our inpatient population. So behavioral traits, these guys are going to have a tendency to exaggerate the closeness of relationships and dramatize minor events. Speech is going to be really theatrical. It's going to be full of superlatives, but it's going to really lack any specific details. They're going to have concern with impressing others, often spending excessive time, money, and energy on their appearance. They're going to kind of overdress and engage in very flirtatious behavior across social, occupational, and professional settings. So this is the person that might decide to turn on flirtatious for means of, getting a better job or whatnot. Emotional expression, they're emotionally expressive. They kind of have this exaggerated, shallow, and insincere emotions to them. They do have rapid shifts where we might be laughing one second and sobbing the next. And it's usually seemingly forced. Others will think that it's forced change of emotions. Very self-absorbed, very highly suggestible, and quick to agree with others for gain of attention. With their attention-seeking behavior, they're very much uncomfortable when they're not the center of attention, so they're going to use dress, compliments, and even dramatic actions to draw attention to themselves. They may create exaggerated stories, cause public scenes, or even faint just to get attention. Many respond with temper tantrums or crying when they're feeling unappreciated. So, center of attention and anything that I can do to keep it. With their relationships, they very much exaggerate the intimacy of relationships, calling people that just might be a passing acquaintance like their dear friend or their best friend. They engage in inappropriate public displays of emotion, such as excessive hugging or crying. Relationships often are manipulative, and people that encounter them often feel like they've been used. Some physical complaints. These guys frequently complain about vague or exaggerated physical issues that often tie into the amount of attention they receive. So, your nursing actions. You want to provide feedback, give constructive feedback on social interactions, their dress, and their nonverbal behavior. So, if they come out very provocatively dressed, that's not appropriate. We need to change back into something that's appropriate. If they're rolling their hospital pants down and leaving their gown open, that's not appropriate. And we want to focus on the appropriate alternatives. So recommending proper personal space. Let's shake hands instead of hugging. Social training skills. You want to discuss social relationships to explore how the clients perceive others' reactions and behaviors. Role play and teach the social skills in a safe environment. What's good eye contact? How are we respecting people's personal space? Let's practice active listening. We want to outline appropriate topics for different types of relationships. So, what's the difference between a casual acquaintance, a close friend, and a family member? We also want to build esteem. So, discuss personal strengths, provided specific feedback on positive qualities they have, encourage assertive communication using I statements that can help the client express their needs more appropriately, and reinforce the nurse's confidence in the client's ability to promote self-esteem. Then the last one in this cluster is narcissistic personality disorder. So narcissistic personality disorder is really going to have pervasive pattern of grandiosity. So it could be fantasy or it could be behavior. They have this need for admiration and an overall lack of empathy. It affects about 6% of the population. It is more commonly seen in men. Traits often present in adolescence, but do not necessarily lead to this personality disorder in adulthood. So, again, got to be 18 to get one of these. Individual psychotherapy is most effective treatment. Hospitalization is rare unless comorbid conditions require inpatient care. So, what behavioral traits are we going to see? They're going to be arrogant. They're going to have an inability to empathize with others. They might be envious of the success of others and the recognition, believing that it should rightfully be theirs. So, with that, they might belittle others. They might have overt or covert expressions of grandiosity, expect recognition for their perceived greatness. They have a preoccupation with fantasies of unlimited success, power, brilliance, beauty, or ideal love, reinforcing their sense of superiority. Their cognitive and emotional processing, thought process are intact but limited in insight. They have a strong sense of superiority. They're really unable to link their behavior to their personal problems, and they're going to blame others instead. Very fragile self-esteem. They're usually hypersensitive to criticism. And again, they need that constant need of admiration from others. They have that sense of entitlement with unrealistic expectations for special treatment, and people should automatically comply with whatever they wish. Their relationship patterns, they're going to form relationships to elevate their own status, and they often exploit others. They discuss their concerns in lengthy detail, and they truly disregard others' needs and feelings. And right? We said they're not empathetic. They're impatient towards others. In the workplace, they may experience some success due to their ambition and confidence, but they're usually going to struggle to work with others. They're going to see others as inferior. And once somebody gives them criticism or feedback, there's going to be some upheavals there. They often believe that they're underpaid, underappreciated, and deserve higher authority despite lack of qualifications. So, as a nurse, what are you going to do? You want to manage their behavior and attitude, use self awareness to avoid frustration or anger in response to the client's rudeness, arrogance, and criticism. Do not internalize the client's criticism or take it personally. You want to set clear limits on their rude, arrogant, or verbally abusive behavior and clearly explain your expectations. Your treatment approach, provide education about comorbid medical psychiatric conditions, medication regimens, and self-care skills in a matter-of-fact, non-reactive manner. Focus on gaining cooperation with treatment while avoiding engagement in power struggles. We want to promote cooperation. The goal is to maintain professional boundaries and work together for the client's cooperation in their treatment plan. The next cluster group is our cluster C. Cluster C is our anxious and fearful clients. This is going to be our avoidant personality disorder, our dependent personality disorder, and our obsessive personality disorders. I find these to be the easiest ones for me to remember. So the avoidant personality is just going to have a pervasive pattern of social discomfort, low self-esteem, hypersensitivity to negative evaluation. It occurs in about 2 to 3% of the population. It's common in both men and women equally. Individual psychotherapy is the most effective treatment. Behavioral traits. Overly inhibited as a child, avoiding unfamiliar situations or people beyond typical developmental expectations. They're going to be anxious with physical signs of like fidgeting, poor eye contact, and reluctant to ask questions or make requests. They're going to be really sad, anxious, socially awkward. They may be withdrawn, especially if they're criticized or rejected. They're going to get really withdrawn. Our cognitive and emotional practicing, low self-esteem, hypersensitive to negative evaluation. It's going to lead them to feel that they are inferior. They're going to be fearful of making mistakes, being humiliated, or embarrassing themselves, which is going to lead them to avoid all new situations. This is somebody who's not going to want to do group therapy because they're going to be very uncomfortable. They're going to have a strong desire for social acceptance and intimacy, but their fears of rejection and humiliation kind of hold them back from making those social contacts. So with that, they tend to avoid relationships or situations where rejections, criticisms, or disapprovals may occur. There's social, occupational behaviors. Some of these guys can be very successful in their roles because they're eager to please people and gain approval. But likely to reject promotions or avoid more rewarding opportunities due to fear of failure or social discomforts. So, your nursing actions, right? We want to provide support and reassurance. We want to offer consistent support and reassurance to help reduce anxiety and fear of judgment. We want to create a non threatening environment where clients can explore positive self aspects and gain insight into self criticisms. We want to promote self-esteem by encouraging self-affirmations and positive self-talk to build confidence and enhance self-worth. We want to use cognitive restructuring techniques such as reframing and decatastrophizing to help challenge negative thoughts and perceptions. We want to teach and practice social skills, provide gentle and patient guidance in teaching social skills, Practice these skills in safety of the nurse-client relationship, which will allow the client to build confidence at their own pace and understand that although the client might have significant social fears, they also deeply desire meaningful connections and will be motivated to engage in social interactions with the appropriate support. We want to make sure we're using a gradual approach. We need to be patient and realistic in our expectations and understanding that social skills will take time to develop and clients need consistent support to challenge their fears. Next, we have our dependent personality disorder. So the core characteristics of this, they're going to be pervasive. They're going to have an excessive need to be taken care of, leading to submissive, clingy behavior with fear of separation. These behaviors are often intended to elicit care from others, occurs in about 1% of the population, tends to run in families, higher prevalence in the youngest child. These clients are going to seek treatment because of feelings of anxiety, depression, or somatic complaints. Behavioral traits, they're anxious, they're self-critical, and they are very easily hurt by others. They frequently feel unhappy or depressed, particularly when they fear losing support from someone else. They have fear of being left alone to care for themselves. They believe they would fail without the help of others. They're preoccupied with finding and maintaining relationships to avoid being alone. They may feel helpless or unable to function independently and rely heavily on others to assume responsibilities for them. They have fear of gaining competence because it may lead to loss of support. So I don't want to get a good job because then this person might not take care of me anymore. In extreme cases, they may tolerate poor quality or even abusive relationships just to sustain the support that this bad relationship gives them. So, in our emotional and social processing, they have difficulty initiating or completing daily tasks of independent living. They may tolerate those abusive relationships out of fear of being alone or losing support. When relationships end, clients urgently seek new ones, believing any relationship is better than no relationship. Your nursing actions. So, we want to promote autonomy and self reliance, encourage the client to express their feelings of grief and loss when the relationship ends while fostering independence and self reliance. We want to focus on helping the client identify their strengths and abilities. We want to challenge their belief they cannot function alone. And we want to use cognitive restructuring techniques such as reframing and decatastrophizing to address negative self beliefs. Daily functioning and skill development. We want to help the client gain skills in daily functioning tasks such as meal planning, budgeting, and managing household responsibilities. We want to assess the client's needs and limitations and refer them to agencies that can assist in areas where they may require help. And we want to gradually encourage clients to take responsibility for these tasks, offering guidance and support as needed. For decision making and problem solving, we want to teach problem solving and decision making skills and help the client apply these skills to everyday situations. We want to avoid making decisions for the client or giving unsolicited advice, right? And remember your therapeutic communication. You don't give advice. And we want to encourage healthy relationship boundaries. We want to help the client explore the dynamics of relationships and encourage them to express their needs without fear of rejection or loss of support. And we want to foster awareness of unhealthy patterns in relationships, such as staying in poor quality relationships out of fear of being alone. Next, we have our obsessive compulsive personality disorder. Um, these are about 2 to 8% of the population. Men are twice as effective as women. These guys are going to have a pervasive occupation with perfection, control, and orderliness without the ability to be flexible or open. Individuals often seek treatment when they recognize their life is lacking in pleasure or facing difficulties in work or relationships. Your behavioral traits, they're going to have a serious demeanor responding to questions. They're going to be very precise. They're going to be very detailed. Often feeling the need to be a perfect child. They're going to have been a child that often sought approval. They want to be good. They want to do right. Express emotions in a very constrained manner. They may be anxious, rigid, or emotionally distant. They're going to have a preoccupation with details, rules, schedules, and lists. Um, and that often leads to them missing like bigger picture items. Clients may never complete projects due to these obsessive checking and rechecking and due to their perfectionist driven nature. They're going to struggle with judgment and decision making, often failing to reach decisions due to the need of perfection or fear of making mistakes. They prefer written rules and are very inflexible when adapting to new circumstances or adjusting decisions. They have limited insight and they may not realize their behavior frustrates others and are often stunned when confronted with feedback. For emotional and social processing, these clients have low self esteem. They're usually very harshly critical of themselves, believing they could always do better, be better, no matter the success of the task that they've done. Relationships are strained due to the criticalness and their perfectionist nature. Their attempts to express warmth and affection can come across as stiff or insincere. Um, so for your nursing actions, you want to promote decision making. Um, so help the client shift their focus from perfection to timely completion. That way they're able to do deadlines and make decisions. You want to encourage them to accept less than perfect outcomes. And we want to use cognitive restructuring techniques to challenge that rigid thinking. So questions like, what's the worst that could happen? Or how might others perceive this? So we kind of help change and challenge that perfectionistic mindset. We want to help with facilitating flexibility in their relationships. So, encourage the client to take risks, such as allowing others to plan the family activity or allow somebody else to make the decisions. These can ease control related tensions in relationships. They also can practice negotiation skills to help them relinquish some of their control and improve their ability to work collaboratively. Um, and adjust to maybe somebody else's preference. We want to increase social interactions and emotional expressions. So, encourage the clients to express their emotions more naturally and to acknowledge the importance of emotional warmth in relationships. Help the client explore the impact of their perfectionism on their personal and work life and fostering insight and more adaptive interpersonal behaviors. And we can also do some cognitive restructuring, which incorporates reframing techniques to help the client develop a more balanced approach to their work and personal lives. Encourage clients to recognize that striving for perfection in everyday aspect of life is not only unrealistic, but it's also detrimental to their relationships and their mental well being. So, some age related considerations across the lifespan. So remember their child and adolescence, personality disorders are not diagnosed until they're 18, but traits resembling them can appear early. Some self-centered and immature behaviors in children is completely normal as they develop, but disruptive behaviors like aggression and mood swings could signal an emerging personality disorder. Disruptive behaviors such as oppositional defiant disorder are concerning. And like I said, a lot of times, conduct disorder, or oppositional defiant disorder, we get concerned that it could be evolve into antisocial personality in adults. With adulthood and aging, personality disorders often persist from young adulthood into later adulthood. However, some individuals may experience stabilization of their symptoms. Some clients aging badly Older adults with personality disorders may struggle to accept age-related limitations, resulting in chronic dissatisfaction and disdain for their relationships, potentially leading to isolation. The most common personality in older adults are paranoid, avoidant, and obsessive compulsive. And these individuals are at a higher risk for depression, dementia, and suicide. Challenges for older adults: some may resist help with health, finances, or daily decisions, making aging more difficult. They also face higher risks of depression and social isolation, leading to alienation from their families, caregivers, and healthcare providers. So, nursing considerations, healthcare providers, we need to be compassionate with our care. We need to support autonomy for our clients, and we want to address social isolation and mental health risk. Encouraging positive relationships and promoting mental health can improve quality of life for older adults, and for those with personality disorders. So, our mental health promotion, for our personality disorders, it's treatment focus. We want to target the symptoms of the mood and stabilize it. We want to reduce impulsivity, and we want to improve their social and relationship skills. Addressing unmet needs such as self care, sexual expression, budgeting, psychological distress may improve overall well being of health beyond just addressing psychotic symptoms. Protective factors for the children. Children with more protective factors are likely to develop antisocial behavior later in life. These include social commitment or value placed on education, positive peer relationships, parent or peer disapproval of antisocial behaviors, and a functional family relationship and effective parenting. So, again, those are all protective factors to reduce the risk of antisocial behavior later on in life. Even children at risk for abuse can be protected from developing antisocial behaviors if these factors are present. Lack of protective factors leads to an increased likelihood of antisocial behaviors in adulthood. Your key takeaways here: promoting mental health by addressing multiple areas of life, not just psychotic symptoms, can enhance overall well being. Encouraging positive development, environmental, and supportive relationships can help prevent the onset of personality disorders, particularly that of antisocial. Some self awareness issues. Nurses working with clients with personality disorders can be very emotionally draining. So we need there's challenges in the nurse client relationship. So behavioral change takes time. Clients with personality disorders may take a very long time to change their behaviors or their coping skills, and this can lead to frustration and anger felt by nurses. Maladaptive behavior: these clients will test the limits, they will manipulate the nurse client relationship, and they will make it very difficult to establish clear boundaries. Discussing feelings: nurses should express any feelings or frustrations or angers with their colleagues as to help them cope and prevent burnout. Misleading appearance: clients with personality disorders may appear more functional than they actually are. Unlike clients who are psychotic or severely depressed, these clients might look very well put together and seemingly fine. It can be tempting for the nurse to think clients' lack of motivation or willingness to change. This can lead to frustration, but this may mirror the reactions these clients have encountered from others. Team dynamics: manipulation of staff occurs. Clients with antisocial and borderline personalities may manipulate staff, causing them to disagree or contradict one another. And this is often referred to as splitting. And I mean, the hospital that we do clinical at, they actually will limit the amount of borderline clients on the unit if they can, because of the concern for splitting. Because if these guys will pit day shift against night shift, and day nurse 1 against day nurse 2, just because they're very good at creating that conflict. Um, and there's also different perspectives. Team members may have differing opinions on the client's needs, and this can lead to conflicting approaches. And those borderline and antisocial personality disorders will pick up on that, and they'll manipulate you with it. So, key takeaways: it's important for nurses and staff to work cohesively as a team, be able to discuss frustrations openly amongst one another, not with the client, and ensure consistent boundaries and expectations are maintained to prevent disruption in their care. And that is the end of personality.